I am Peter Duboulay, Professor of Radiology at Harvard Medical School and Senior Vice Chair of Radiology at the Brigham and Women's Hospital in Boston, and I'll be lecturing on sonographic evaluation of early pregnancy loss. I have no financial disclosures to make. The learning objectives of this talk are as follows. After completing this presentation, the learner will understand the limitations of the HCG discriminatory level, will know the sonographic criteria for definite pregnancy failure and probable pregnancy failure in early pregnancy, and will know the sonographic findings that in the presence of an embryonic heartbeat indicate a high risk of impending pregnancy loss. For some introductory comments, somewhere between 10 and 25% of all clinically recognized pregnancies end in pregnancy failure, also known as miscarriage. Ultrasound is the primary method for diagnosing pregnancy failure using criteria, as we'll learn, for definite, probable, and impending pregnancy failure. Sonographic criteria for definite pregnancy failure, as we'll see, should be set to virtually eliminate false positives in order to avoid interventions that could eliminate or damage a normal intrauterine pregnancy. The lecture outline will include discussion of normal ultrasound findings in early pregnancy, some terminology, incidents, and general principles related to early pregnancy loss, and the main part of the talk will be on the sonographic diagnosis of early pregnancy loss, including a number of different scenarios for the sonographic diagnosis. Let's start out by discussing normal ultrasound findings in early pregnancy. The first thing we see on ultrasound at a gestational age of about 5 weeks, scanning transvaginally, is a gestational sac, which just looks like a little small round or oval fluid collection within the uterus with nothing seen within it initially. About a half week later, at 5.5 weeks, we first see the yolk sac within the gestational sac. A half week later, at 6 weeks, we see typically an embryo with a heartbeat. And a week after that, at 7 weeks of gestational age, we see the amnion around the embryo for the first time. These are findings, these ages and findings are accurate to within typically about 3 days or so, or a half a week. And here are some ultrasound examples of these findings. Here at 5 weeks, we see a little nondescript oval fluid collection in the uterus. It has no visible contents. We can call it a nonspecific sac-like structure within the uterus. At 5.5 weeks, we see this little circle within the gestational sac, but still no embryo. This is typical for a 5.5 week pregnancy. At 6 weeks, we see an embryo with a heartbeat beside the yolk sac, as seen here just above the pointer. And at 7 weeks, we see for the first time the amnion around the embryo. So here is the embryo, there's the yolk sac, all within the gestational sac, and we're seeing the amnion for the first time apart from the embryo. It's very important to know the normal sequence of findings in early pregnancy because disruptions or deviations from the normal sequence of findings indicates either definite or probable or possible pregnancy failure. Let's move on to the second part of the talk, some terminology, incidents, and general principles related to early pregnancy loss. One term that you may hear, one term that one does hear, is miscarriage. Miscarriage is defined as spontaneous loss of an intrauterine pregnancy prior to 20 weeks of gestation. Another term is early pregnancy failure or early pregnancy loss, and that's often used to describe the spontaneous loss of an intrauterine pregnancy in the first trimester. So it's an earlier, the earlier part of the pregnancy that is similar to a miscarriage, but it's when it happens in the first trimester. Other older terms should really be avoided, such as spontaneous abortion or blighted ovum. As we saw on an earlier introductory slide, the incidence of early pregnancy loss is about 10 to 25%. And the highest rate of miscarriage is early in pregnancy, prior to 6 weeks. It's the highest at that point. It's somewhat less between 6 and 7 weeks, decreases at 7 to 8 weeks, and it progressively declines. The rate of miscarriage progressively declines as pregnancy proceeds. Chromosomal anomalies are thought to be the most common cause of miscarriage, but in many cases of miscarriage, we have no good explanation or no clear and definitive explanation for why it occurred. Many of the ultrasound diagnostic criteria that I'll be talking about here came from, at least in part, a consensus conference on early first trimester sonography that was run by the Society of Radiologists in Ultrasound to come up with guidelines for diagnosing miscarriage and excluding a viable intrauterine pregnancy. That consensus conference was held in Baltimore in October of 2012. I was the moderator of that consensus conference. The panelists included a number of radiologists, obstetrician gynecologists, and emergency medicine physicians. And the conclusions of that consensus conference were published in the New England Journal of Medicine in 2013. The conclusions of that conference are the criteria for diagnosing miscarriage that have been adopted in societies, medical societies throughout the United States and in many countries around the world. So let's look at what the potential consequences are of a false positive or a false negative diagnosis of early pregnancy loss, or in other words, a false positive diagnosis of a failed pregnancy or a false negative diagnosis. What do we mean by a false positive diagnosis? Well, false positive diagnosis of failed pregnancy is an erroneous diagnosis of failed pregnancy. In other words, you diagnose pregnancy failure when it's actually a potentially normal pregnancy. That has a really bad consequence. If you diagnose pregnancy failure, definite pregnancy failure, when there's a chance of a normal intrauterine pregnancy, that may lead to uterine evacuation when there's a potentially normal intrauterine pregnancy. That's a pretty horrible consequence. False positives have a pretty horrible consequence. What about false negatives? You should diagnose pregnancy failure or pregnancy loss, but you don't. The consequence there is delayed intervention for failed intrauterine pregnancy. It is not great, but it's not a terrible consequence. In other words, the consequence of a false positive diagnosis of failed pregnancy is much worse than the consequence of a false negative. Saying there is a failed pregnancy when you shouldn't is a lot worse than failing to diagnose pregnancy loss when you should. And because of that, the criteria for pregnancy failure should be set to virtually eliminate false positives. They should also be set to apply to a broad range of ultrasound facilities that meet at least minimum quality criteria for performing ultrasound. They should not be set, the criteria should not be set to apply solely to experts in early obstetrical ultrasound. And now let's move to the main part of the talk, which is the sonographic diagnosis of early pregnancy loss. And we're going to consider three scenarios in which ultrasound is relevant to the diagnosis of early pregnancy loss. All of these three scenarios apply in the situation where we have a positive HCG and normal adnexa. Positive pregnancy test, nothing seen in the adnexa. Three scenarios. Scenario 1, you see no intrauterine pregnancy in this woman with a positive HCG and normal adnexa. That's also known as a PUL, or a pregnancy of unknown location. The second scenario we'll consider is we do see an intrauterine pregnancy, but we don't see a heartbeat. And the third scenario is we see an intrauterine pregnancy with a heartbeat. Those are three scenarios that we will consider. And the key questions for each of those scenarios is seen here. If the ultrasound finding is no intrauterine pregnancy, the key question is, can a single HCG value, the discriminatory level, confidently exclude a viable intrauterine pregnancy? Second is when there's an intrauterine pregnancy but no heartbeat, what findings indicate definite pregnancy failure and what findings are suspicious for pregnancy failure? And finally, if you see an intrauterine pregnancy with a heartbeat, what findings suggest impending pregnancy failure? So let's move to the first of those scenarios. And again, the question is, when you have a woman with a positive HCG, normal adnexa, no intrauterine pregnancy seen, can a single HCG value exclude a viable intrauterine pregnancy? So what is the so-called discriminatory level? It's a concept that was originated by Nicholas Kadar in 1981, and it's defined as the HCG level at or above which a normal intrauterine pregnancy is consistently seen. With improvement in ultrasound technology, the discriminatory level that's been reported has consistently decreased. In 1981, when Nicholas Kadar wrote the paper defining the discriminatory level, only transabdominal ultrasound was around, and at that point the reported discriminatory level was 6,500. In other words, the HCG level at or above which you consistently saw an intrauterine pregnancy in 1981 was 6,500. As ultrasound technology improved, the HCG level at which you consistently saw a pregnancy, in other words, the discriminatory level, dropped. And with the introduction of transvaginal ultrasound, the discriminatory level has been reported in a variety of studies as being between 1 and 2,000 milli-international units per ml. So what's the rationale or potential rationale of the discriminatory level? Well, if it works, if we use a relatively conservative discriminatory level of 2,000, that should mean that if you see an HCG above that discriminatory level of 2,000 and you see nothing in the uterus on ultrasound, if the discriminatory level works, she can't have a normal intrauterine pregnancy because there's no intrauterine fluid collection seen when the HCG is above the discriminatory level. And that would mean the differential diagnosis would be a failed intrauterine pregnancy or an ectopic pregnancy. That is the potential rationale for the discriminatory level. And because of that rationale, at least two different management algorithms have been proposed. First management algorithm says if the HCG is above the discriminatory level and no intrauterine pregnancy is seen, the patient can be given or should be given intramuscular methotrexate for a presumed ectopic pregnancy. Second algorithm that has been proposed is when the HCG is above the discriminatory level and no intrauterine pregnancy is seen, the patient should have a D&C, and then she should be treated for ectopic pregnancy if no chorionic villi are seen. With either of these, when the HCG discriminatory level is above the discriminatory level and no intrauterine pregnancy is seen, if you follow either of these management algorithms, the intervention that would be undertaken would seriously damage or eliminate an intrauterine pregnancy by either giving methotrexate or doing a D&C. So that is the theory of the discriminatory level and the proposed, or what have been proposed in the past as management algorithms. Now here's the reality. Here is an ultrasound on a woman showing no evidence of an intrauterine pregnancy. The HCG is over 4,000, no visible gestational sac. If the discriminatory level actually worked, this woman would have no chance of having a normal intrauterine pregnancy. But look, 1 month later, she in fact had a normal 9.5-week intrauterine pregnancy, and she ended up with a normal term baby. So in this case, the discriminatory level did not work. In other words, the HCG, more than double the discriminatory level, and nothing in the uterus, didn't exclude an intrauterine pregnancy because there was one. So another case of reality for the HCG discriminatory level. Here we have an HCG above 2,000, it's about 2,200, nothing seen in the uterus. If the discriminatory level worked, this woman couldn't have a normal intrauterine pregnancy, but she did. 6 days later, she has normal twins, and she had normal term twins. We did a study at our own institution, the Brigham and Women's Hospital in Boston, and over a 10-year period from 2000 to 2010, we found 9 pregnancies in which the HCG at the initial ultrasound was over 2,000, as high as 6,500, and nothing was seen inside the uterus. And in those 9 cases, there was 1 or more heartbeats on a follow-up ultrasound, and in the majority of those, 6 of those pregnancies, the woman gave birth to a normal liveborn. So in all of these cases, the HCG discriminatory didn't work. So the recommendation, this comes from the SRU consensus panel, but it is a generally accepted recommendation at this point, is that with respect to the HCG level in pregnancies of unknown location, HCG levels in normal intrauterine pregnancies, abnormal intrauterine pregnancies, and ectopic pregnancies have considerable overlap. And because of that, if ultrasound shows no evidence of an intrauterine or ectopic pregnancy, don't intervene based on a single HCG measurement. Get at least one follow-up ultrasound and HCG in order to avoid damaging a potentially normal intrauterine pregnancy and to avoid giving methotrexate to a woman who has a failed intrauterine pregnancy. So let's move on to the second of our three scenarios. Woman has an HCG, normal adnexa, and has an intrauterine pregnancy, but you don't see a heartbeat. In this case, the questions we'll address are what findings indicate definite pregnancy failure and what findings are suspicious for pregnancy failure. So the criteria for pregnancy failure on ultrasound or pregnancy loss on ultrasound fall into three categories. One type of criterion for diagnosing pregnancy failure is non-visualization of a heartbeat by a certain embryonic size. In other words, a crown-rump length without a heartbeat. Another type of criterion for pregnancy failure is non-visualization of an embryo by a certain gestational sac size. In other words, a mean sac diameter without an embryo is another way to diagnose pregnancy failure. And finally, another way to diagnose pregnancy failure is non-visualization of an embryo by a certain point in time. In other words, no embryo is seen after a time interval since a first scan. The criteria that were generally accepted up to the year 2012 were the following. For non-visualization of heartbeat by a certain embryonic size, it was a crown-rump length of at least 5 millimeters without a heartbeat. That, until 2012, was accepted as a criterion for definite pregnancy failure. A mean sac diameter of at least 16 millimeters with no visible embryo was another generally accepted criterion up to 2012. And there were really no well-established criteria for non-visualization of an embryo by a certain point in time to diagnose pregnancy failure. So let's look at these carefully. Let's look at the crown-rump length. So here we have a 1.7 millimeter crown-rump length, a tiny little embryo, and we see a heartbeat. In fact, we expect to see a heartbeat. We expect to see a heartbeat anytime we see an embryo. So the heartbeat is usually visible as soon as the embryo is visible. But the key question to diagnose pregnancy failure with certainty is not when a heartbeat is usually visible, but when, at what crown-rump length is the heartbeat always seen in a normal pregnancy? There have been a number of studies that have addressed this question. In other words, that have addressed the cutoff value for the crown-rump length, above which cardiac activity is consistently visible on transvaginal ultrasound in a normal pregnancy. And the early studies around the early 1990s concluded that cardiac activity is always visible when the crown-rump length is 4 or 5 millimeters, depending on the study. And because of those studies, 5 millimeters became the generally accepted cutoff for diagnosing definite pregnancy failure. But over the last several years, concerns with those early studies, with the data from the early studies, arose. One type of concern is that when people look back at them, they realize that the study populations in those early studies were quite small, which meant that there was a pretty wide 95% confidence range of the specificity. So they weren't really that reliable for diagnosing pregnancy failure. In addition, around the year 2010 or 11, several cases of embryos with crown-rump lengths of 5 to 6 millimeters and no cardiac activity were reported that subsequently proved to be normal, which meant that the crown-rump length cutoff of 5 millimeters without a heartbeat didn't work in those reported cases. And finally, studies of inter-observer variability of the crown-rump length measurement showed that there is a inter-observer variability of about plus or minus 15%. So one practitioner's 6 millimeter crown-rump length may be 15% higher or 6.9 millimeters when measured by others. So, using 5 millimeters is not that safe because your measurement of 5 millimeters may be different than another observer's measurement on the same pregnancy. So because of that, the SRU consensus panel recommended, and in general, this recommendation is now generally accepted, that crown-rump length of 5 millimeters and no heartbeat was not stringent enough to diagnose definite pregnancy failure, and the accepted criterion now is up to 7 millimeters. A crown-rump length of 7 millimeters and no heartbeat indicates definite failed pregnancy. When the crown-rump length is less than 7 millimeters and there's no heartbeat, that's suspicious for a failed pregnancy, but not definitive. And here are a couple of examples. Here is a crown-rump length of 7.1 millimeters, no heartbeat. That indicates definite pregnancy failure. Here is a crown-rump length of about 3 millimeters. There's no heartbeat. That is suspicious but not definite for pregnancy failure. What about the mean sac diameter? Here there were a number of early studies that looked for the cutoff value of the mean sac diameter above which an embryo is consistently visible on transvaginal ultrasound if the pregnancy is normal. In 2 early studies, they found that with a mean sac diameter of 16 or 17 millimeters, you should always see an embryo if the pregnancy was normal. Those were the early studies, and because of those, 16 millimeter mean sac diameter with no embryo became the generally accepted cutoff for diagnosing pregnancy failure based on the mean sac diameter. But just like the crown-rump length, around the year 2010-2011, concerns were raised. Again, small study populations had been used for the early studies of the mean sac diameter, just like the crown-rump length. People started reporting a number of cases of embryos with mean sac diameter bigger than 16 millimeters and no embryo or no cardiac activity that subsequently proved to be normal. And there's inter-observer variability of the mean sac diameter measurement, just like the crown-rump length. And because of that, the criterion for definite pregnancy failure based on the mean sac diameter without an embryo was raised from 16 millimeters to 25 millimeters. So now The criterion to diagnose pregnancy failure based on a gestational sac with no visible embryo is that the mean sac diameter has to be at least 25 millimeters to diagnose definite pregnancy failure. If the mean sac diameter is 16 millimeters or above, up to 24 millimeters, and there's no embryo, that's suspicious but not definitive for pregnancy failure. And here are a couple of examples. Here is a gestational sac. If we take the average of these three measurements, we get a mean sac diameter of almost 28 millimeters. And there's no embryo seen. There is a yolk sac, no embryo. This meets the criterion for definite pregnancy failure because the mean sac diameter is bigger than 25 millimeters with no embryo. Here, if we take, in this case, if we take the three measurements, we get a mean sac diameter of about 17 millimeters and there's no embryo. That's suspicious for pregnancy failure. Anytime the mean sac diameter is 16 to 24, as it is in this case with no embryo, that's suspicious for pregnancy failure. And then there are some time-based criteria for pregnancy failure that were given the stamp of approval by the SRU consensus panel and that have been accepted generally. If you do an initial scan and you see a gestational sac with no yolk sac, just a little round or oval fluid collection in the uterus with nothing in it, if 2 weeks later or greater there is still no embryo visible, that's definite for pregnancy failure. If you see a gestational sac with a yolk sac, if 11 days later or more there's still no embryo, that means definite pregnancy failure. There are some lesser time gaps, 7 to 13 days without an embryo after seeing a gestational sac. Indicates is a finding that's suspicious for pregnancy failure. 7 to 10 days after a gestational sac with a yolk sac if there's no embryo, or if there's no embryo, at least 6 weeks after the woman's last menstrual period. Those are suspicious but not definitive for pregnancy failure. And here are a couple of examples of time-based criteria to diagnose pregnancy failure. We see on the initial scan a small gestational sac. 15 days later, there's still no embryo. The sac has grown a bit, but there's still no embryo. And that meets one of the time-based criteria for definite pregnancy failure. Here's another example. Initial scan, we see a gestational sac with a yolk sac. 12 days later, we see the yolk sac again, but there's still no embryo 12 days after the initial scan, and that also meets one of the criteria listed on the earlier slide for definite pregnancy failure. This is an example of a time criterion that's suspicious but not definite for pregnancy failure. Initial scan, we see a gestational sac, no yolk sac, just a little gestational sac. 8 days later, no embryo, and this meets one of the criteria that's suspicious for pregnancy failure. And so is this one. We see a gestational sac with a yolk sac. 7 days later, still no embryo. That meets one of our criteria that's suspicious for pregnancy failure. And we expect to see an embryo 6 weeks after the LMP. This is 6.4 weeks, 6 weeks and 3 days after the LMP, and we're not seeing an embryo, suspicious but not definitive for pregnancy failure. There Other criteria that are suspicious for pregnancy failure, including an empty amnion, which I'll show you in a minute, or a large yolk sac. Those are suspicious for pregnancy failure. So what is the empty amnion? Well, if you remember back to one of the first slides that I showed you, you'd typically see the embryo at 6 weeks, the amnion at 7 weeks. If you see an amnion with no embryo, so you should see the embryo before the amnion. If you ever see an amnion with no embryo, that's abnormal and indicates a high suspicion for pregnancy failure. As in this case, here we can see two little circles in the gestational sac. One is the yolk sac, one is the amnion, and we're not seeing an embryo. So we're seeing an amnion with no embryo. That is suspicious for pregnancy failure. And so is a large yolk sac. A large yolk sac, one that's bigger than 6 or 7 millimeters, as in these two women, a 7.2 millimeter yolk sac, a 9.1 millimeter yolk sac. These are very worrisome, very suspicious for pregnancy failure. So we have a whole series of criteria for definite pregnancy failure that we talked about, including a crown-rump length of at least 7 millimeters and no heartbeat, mean sac diameter criteria, time criteria for definite pregnancy failure, and a variety of ultrasound findings that are suspicious but not definitive. Crown-rump length criteria that's suspicious, mean sac diameter, time criteria, empty amnion, and enlarged yolk sac. What do we do with these suspicious findings? In these cases, the appropriate step is to get a follow-up, usually a week later after a suspicious finding, to either, in some cases, because it's suspicious but not definite, occasionally the pregnancy will be fine, most of the time it won't be. And now let's move to our last scenario. We have a woman with a positive HCG and normal adnexa, and you see an intrauterine pregnancy with a heartbeat. So you certainly can't diagnose pregnancy failure, pregnancy loss because there's a heartbeat. But the question that we're going to ask here is, when you see an intrauterine pregnancy with a heartbeat in early pregnancy, what findings suggest impending pregnancy failure? Not current because there's a heartbeat, but a pregnancy failure that is likely to occur soon. The risk indicators of impending pregnancy failure on ultrasound when you see a heartbeat are a slow or irregular embryonic heartbeat, a large subchorionic hematoma, small gestational sac size in relation to the embryo, an expanded amnion, a large yolk sac, or sliding gestational sac. And I'll show examples of each of these. First was a slow heartbeat. So what heartbeat is slow? Well, as you can see from this graph, if you have a very early pregnancy, crown-rump length 4 millimeters or less, which corresponds to 6.2 weeks or less. If the heart rate is above 100, the pregnancy survival rate levels off at just about 90%. If the heart rate in these very early pregnancies, crown-rump length up to 4 millimeters, is 90 to 99, there's a reasonable but not great survival rate, and once the heartbeat is less than 90, there's a very low chance of survival. With a crown-rump length of 5 to 9 millimeters, 6.3 to 7-week gestational age, those numbers are all 20 beats per minute higher than in the early pregnancy. The outcome is levels off at a good high rate of survival when the heartbeat is 120 millimeters or greater, borderline when it's 110 to 119, and relatively poor, poor to very poor, when it's below 110. Putting these in a table, you can see that a slow heartbeat very early on is less than 90. Normal is at least 100. Borderline is in between. 6.3 to 7 weeks, or crown-rump length of 5 to 9 millimeters. The heart rate is slow, indicating high likelihood of impending pregnancy failure. When the heart rate is below 110 beats per minute, it's normal when it's above 120, and borderline in between. And here's an example of a slow heartbeat. We see a small gestational sac, about 4 millimeters. The heart rate looks slow when we look at it with our eyes. We measure it with M mode, and it's 82 beats per minute, indicating a high likelihood of impending pregnancy failure. And there was a demise 5 days later on follow-up. Crown-rump length here is between 6 and 7 millimeters. So the criteria for a slow heartbeat are somewhat higher than with a very tiny crown-rump length. Here it's 102, and from my earlier table, that's a slow heart rate for a crown-rump length of 6.7 millimeters. And sure enough, there was demise 1 week later. Here there's an irregular heartbeat. If you look carefully at this heartbeat, it has a beat, beat, stop, beat, beat, stop, beat, beat, which you can also see beat, beat, stop, beat, beat, pause, beat, beat. It's a pattern called bigeminy. It's an irregular heartbeat, and that's suspicious for impending pregnancy failure, and there was demise on a follow-up scan 3 weeks later. What about subchorionic hematomas when you see an embryo with a heartbeat? What's the clinical significance? Well, subchorionic hematomas have been classified as small, medium, and large based on a number of criteria: subjective assessment, fraction of the gestational age that's surrounded by a hematoma, or an estimated volume of the hematoma. But the key is whether a subchorionic hematoma is small, medium, or large. Most studies of subchorionic hematoma, when there is a heartbeat, find that a large subchorionic hematoma carries a somewhat elevated risk of subsequent or impending pregnancy failure. The likelihood of pregnancy failure with a large subchorionic hematoma, if there is a heartbeat, is there's about a 20 to 40% chance of pregnancy failure. A small to moderate subchorionic hematoma in the presence of a heartbeat carries little or no added risk of subsequent pregnancy failure. So what's somewhat worrisome is a large subchorionic hematoma. Small to moderate doesn't mean very much. And here's an example. This is a large, here we can, large subchorionic hematoma. There's a heartbeat. There's the gestational sac, and a pretty big hematoma going around it. Again here, seen. So that's a large subchorionic hematoma, at least subjectively large, and that's suspicious for impending pregnancy failure. Another large subchorionic hematoma. There's a gestational sac, big hematoma around it. There's a heartbeat, big hematoma around it. So it's somewhat suspicious. There's about a 20 to 40% chance that this pregnancy won't make it. But at the same time, there's a 60 to 80% chance that it will make it, and this was normal at 9 weeks. Here is a pregnancy with a heartbeat at about just about 7 weeks. There's a small to moderate subchorionic hematoma. This carries little to no risk, and the pregnancy was fine when we scanned through it 5 weeks later. Another ultrasound finding in conjunction with a heartbeat that is worrisome or suspicious for impending pregnancy failure is a small gestational sac size. And you can diagnose small size in relation to the embryo by quantitative criterion. One that's been suggested is when the mean sac diameter minus the crown-rump length is less than 5 millimeters. That indicates small sac size. Or you can look at it visually and subjectively assess the gestational sac as being too small. And in one study with small gestational sac size in 16 cases of early first trimester pregnancies that had normal heart rates but small sac size, 15 of the 16, over 90%, ended in pregnancy loss. So small sac size in conjunction with a heartbeat is worrisome. Here is an example. Here's an embryo. There is a normal heartbeat, but the gestational sac looks very small relative to the size of the embryo. Not much fluid around the embryo. And sure enough, there was demise on a follow-up scan 6 days later. So the small sac size in this case indicated a high likelihood that came to be of a pregnancy failure in the future. And here is another one. You see an embryo in here. The gestational sac is not very big around it. If we take the mean sac diameter and subtract the crown-rump length, mean sac diameter was 15.5, crown-rump length 12.8. The difference is less than 5 millimeters, suspicious for impending pregnancy failure. We talked about an empty amnion in the earlier scenario as being indicative of high likelihood of pregnancy failure. If you see an expanded amnion in conjunction with a heartbeat, it's not pregnancy failure, but it's suspicious for impending or upcoming pregnancy failure. Remember that the amnion normally appears close to 7 weeks or slightly before, when the crown-rump length is 6 to 10 millimeters. If you identify the amnion when the crown-rump length is less than 5 millimeters, it's worrisome for impending pregnancy failure. And here's an example. We see a 3 millimeter embryo. There's the yolk sac. There's a heartbeat. But notice that the amnion is expanded around this embryo when it shouldn't be. You shouldn't see the embryo, you shouldn't see the amnion expanded around the embryo until the embryo is 6 to 10 millimeters, not 3 millimeters. So this is called the expanded amnion, and even though there is a heartbeat, it's suspicious for impending pregnancy failure, and a week later there was no heartbeat left. In the earlier scenario, I indicated that an enlarged yolk sac, when there's no embryo and an enlarged yolk sac, that is worrisome for pregnancy failure. If there's an enlarged yolk sac in conjunction with a heartbeat, that's suspicious for impending pregnancy failure. And here you can see an embryo with a heartbeat, a big yolk sac beside it measuring 9 millimeters, and there was demise a week later. And here is another case of an enlarged yolk sac. Here we have an embryo with a heartbeat. The yolk sac is big, as we see on the bottom slide. On the bottom image. It's about 9 millimeters in this 7-week case. Yolk sac too big, worrisome for pregnancy failure, and sure enough, there was demise 1 month later. And the final sign of impending pregnancy failure when there's a heartbeat is a sliding gestational sac. So if we look at this pregnancy on this image, we just see a pregnancy with a heartbeat. But when we watch it, you can see it sliding along the sac, along the uterus. And that is a very suspicious finding. So there was a heartbeat, but a sliding sac, suspicious for impending pregnancy failure, and the gestational sac had passed and was no longer present 6 days later. So to conclude, we looked at criteria for definite pregnancy failure, including a crown-rump length of at least 7 millimeters and no heartbeat, a mean sac diameter of at least 25 millimeters and no embryo, some time-based criteria for definite pregnancy failure. We also looked at the situation when ultrasound demonstrates an embryo with a heartbeat. We looked in that situation for what signs on ultrasound are indicative of impending pregnancy failure, including a slow or irregular embryonic heartbeat, large subchorionic hematoma, small sac size, expanded amnion, large yolk sac, or sliding gestational sac. Here are a number of key references that touch on these topics or that delve into these topics of diagnosis of early pregnancy loss. So I hope that this discussion has been helpful to you to understand how we use ultrasound to diagnose pregnancy failure, definite failure, suspicious failure, or impending failure. And I thank you all for your attention.